the objectives today, I'm just going to briefly review type 1. We're not going to go into much detail there. Understand that ketones, identifying that they have them is the first sign that you are lacking in insulin. Most patients can manage sick days at home if appropriate steps are taken, and pediatricians who are out in the community can be our first line of defense against these kids developing DKA and coming in very sick. So this is just a natural history slide on type 1 diabetes. As you all know, it is started by a #1 genetic predisposition to getting diabetes. You have a trigger of some sort that triggers your autoimmune response to happen. You then develop circulating autoantibodies that do damage to the beta cell. And by the time you come in with high enough blood sugars, you've lost 80% of your ability to make insulin, and your blood sugars are high enough. So in a happy patient who is making insulin and is able to bring sugar into the cell to make energy, everything is good. Their sugars are normal, they don't have any ketones, they're making energy normally. In a patient with type 1 diabetes or a type 2 who is on insulin and becomes sick, what happens is that you have these cytokines develop that increase your counter-regulatory hormones to insulin. You then develop peripheral insulin resistance, and all of these things lead to hyperglycemia. So that is one arm of developing DKA. The other arm happens when you, instead of being able to use glucose to bring into the cell to make energy, because you don't have enough insulin on board, is then you start breaking down triglycerides to free fatty acids, and as a byproduct of that, you develop ketone bodies. That's the other arm of developing problems with DKA. So in our sick day management, we're going to address both of those arms. So in a type 1 patient, when this happens is you develop metabolic acidosis, you get progressive dehydration, and you come in with DKA. In a type 2 patient, though, you may not develop significant acidosis because you still make insulin. Those patients present with hyperosmolar, hyperglycemia hyperosmolar syndrome, and those patients are severely dehydrated, usually with sugars over 1,000. So just to review, DKA is a preventable and life-threatening condition. You have hyperglycemia, metabolic acidosis, ketosis, and dehydration. According to the CDC, they reported this data from 2009 to 2014. That seems like pretty old data, so this morning I Googled it to see if there was some newer data. And they just updated in 2018 that most of these admissions for DKA were below the age of 45. So we know that younger patients are more at risk, but they don't have new information there. So sick day management is an integral part of diabetes management. PCPs are the first point of contact for a lot of these kids. Early identification that urine ketones are elevated may help them develop a care plan so that they don't get sicker with DKA. And it may give you guys, for the PCPs, something to talk about besides their illness. At least if you can mention to them, do you know your sick day management guidelines? Have you started that? Or call the endocrine office to get that clarified. That would be great. Okay, so we're gonna just introduce this case, and I just want to have you guys keep it in your mind as we talk about things. You can see how the things that we talked about applies to this patient. So this is a 6-year-old girl. She has a 2-year history of type 1 diabetes. She comes into the PCP's office with cough, fever, body aches. She is not vomiting, but her oral intake has been poor. You tested her for flu and she's positive. So what do you tell them about diabetes? You address their flu symptoms. What do you say about their diabetes? So we developed a sick day pathway guideline in partnership with the Arkansas Children's Care Network. Their goal was to publish guidelines on all sorts of things from asthma to sick day management to other things. I'm not sure where they are in their process right now. We used our current guidelines that we give to patients as the foundation to that guideline. And then our focus was basically what we talked about is identifying at-risk kids. So if you look at the end of your paperwork, the end of my slides, there is the pathway for sick day on injections. Behind it, there's a sick day pathway for patients on pumps. And then behind that page is what we share with our patients and families as our education piece. Okay, so how do you assess these patients? You assess whether they've been vomiting, because that's really important. You know, we depend on these kids to drink a lot. And if they're vomiting and they can't hold anything down, that's really the end of the story. You need to send them to the ER. IV is the only way you're going to get them fluids. If they have abdominal pain, poor PO intake, fever, mental status changes, obviously pointing towards DKA, rapid breathing, Kussmaul respirations pointing to DKA, and the assessment of their urine ketones. So there are two ways that patients assess ketones at home. Number one is through a urine dipstick. And so you basically dip that dipstick into the urine sample, or you can catch it midstream, and you read it 15 seconds later. And you compare the color to the chart that is on the bottle. If it's smaller trace, we'll talk about that in a minute. Basically not very concerning. Moderate and above is where we want them to intervene. There are some patients who have blood ketone strips at home because their kid gets urine ketones all the time. And they're not really sure whether this is an emergency or not. So they get blood ketone strips. When you look at a urine ketone, you're actually looking at maybe some old data. So depending how much they have drank and when the last time they voided, urine ketones can be many hours behind what the kid is actually experiencing at the minute. And so if you do a blood ketone check, you get a real-time check as to what their ketone status is. So on the blood ketone, basically anything less than 0.6 is normal. 0.6 to 1 is someone who has 0.6 to 1 is smaller trace, 1 to 1.5 is moderate ketones, and over 1.5 is large ketones. So how do you include and exclude kids to follow this pathway? So the inclusion criteria to follow the pathway is a patient who is on insulin, a type 1 or a type 2, someone who has small, moderate, or large ketones. The kids you exclude are people who are not on insulin. So if you have a new onset, you check urine ketones, they're not going to be able to follow this at home because they don't know what to do. So those patients automatically get sent to the ER. If they're vomiting with with PO intolerance and they have large ketones, so they're already towards the end of almost developing DKA, those patients should not be included into this pathway. They've had moderate to large ketones over 6 hours, and that could be by parent self-report, saying that, we've been dealing with this for 6 hours, she's not getting better. Those kids go to the ER. Any signs of DK, mental status changes, rapid breathing, moderate to severe dehydration. So there are some important concepts to keep in mind regarding following these pathways. They shouldn't ever skip insulin when they're sick, because insulin is what's going to start turning around the pathway of ketosis and allowing them to stop the cycle to metabolic acidosis. They're instructed to check urine ketones if their blood sugar is over 240. However, if you can imagine a 6-year-old who has not been eating very well and is sick and has all those counter-regulatory hormones to insulin, their sugar may be 100, but she's vomiting. they should check ketones anytime that they are sick as well. You need to drink to rehydrate yourself. You also need to drink to continue to flush those urine ketones out so that you can get a better real-time assessment of your ketone status. And then you also need insulin to clear the ketones. Ill appearing, unable to drink, go to the ER, we've talked about that. So we recommend patients drink age in ounces. That means if you're 6, you drink 6 ounces per hour. If you're 18, you drink 18 ounces per hour until your ketones are cleared. If you are on an insulin pump, you need to assume that there's something going on with your pump or your site, that you're not getting insulin. So you need to get fresh insulin in your pump. You need to change out your pump site. Do that as soon as possible. So I recommend my kids on pumps to do a shot right away. Because you know when you do a subcutaneous shot, you are getting insulin in and you're not depending on that pump to give you the insulin. Okay, so if you have small ketones in your urine, you basically, that's just a very early warning flag that you might be getting sick. So you just drink your age in years and continue to follow your ketones. So if you, so if they're due for a shot with a meal, they do that shot for their meal. They don't do extra injections of insulin. And it doesn't matter if their blood sugar is 400 or 240. If they have small ketones, they can wait for their next meal to do an insulin shot. Diabetes is really gray. So when you talk to family members, they may say, no way, I'm gonna wait. I'm gonna do a shot right now for that blood sugar of 500, okay? That's fine, it doesn't matter if that's what they normally do, they can go ahead and do that. However, when we do the teaching on the inpatient side, we don't typically have them do that. So they drink and then they wait until their ketones clear. Now, if they could potentially, as they follow the small ketone pathway, get moderate to large ketones, and then they would follow that pathway. So if you have moderate to large ketones, these patients are at highest risk of developing DKA. They need extra insulin, so we ask them, you know, the residents know at this point now, we always say Q3 check and correct. Okay, that means every 2 hours, 2 to 3 hours, they need to check their blood sugar and they need to correct that blood sugar with insulin. And if they have large ketones and they're over the age of 10, you add 4 extra units. If they're under the age of 10, you add 2 extra units to their correction. So that means if they have a correction scale of 1 for 50 over 150, for example, then they are supposed to get 3 extra units for insulin just for the high blood sugar. They would, for large ketones, they would add, 4 units at 7 units for someone over 10. For anyone less than 10 years old, you add 2 units, that's 5. It's really testing my math skills this morning. On patients on an insulin pump, once they've re-sited and done everything what they need to with that pump site, we have them do an extra 20% on their basal rate, so their background rate we also increase by 20% for 12 hours. If someone uses their pump to do a correction, for example, and they didn't do anything, they didn't change out their site, they didn't follow our recommendations, and their sugar doesn't drop by 100 in an hour, you assume that's a bad site. Now, sometimes they could put in a new site. They said, we just did a new site. They didn't drop, recite. You're gonna have to recite again. You don't know how many kids that come in to the hospital for poor sites with DKA. Those, some of them might be preventable, some of them are not, but most of them typically are. When we drink with moderate to large ketones, we kind of drink types of fluids based on blood sugar levels. So if you realize that we have to give insulin in as the most critical part of managing this, then if someone has been throwing up and not eating well and they have a blood sugar of less than 100, it's very hard to give them extra correction insulin because they would never qualify for that. So if your blood sugar is over 180, you should drink sugar-free, 100 to 180. half and half, less than 100 full strength sugary drinks so that we can get their blood sugar up to give them extra insulin. Continue to follow your ketones every 2 hours, and then once you have cleared, then that's the end. If you do that for 6 hours and it doesn't clear down to moderate or less, then you go to the emergency room. So going back to our first patient, if you are able to do a blood sugar and ketone check in the office, you can do that. If you don't have the ability to do that, you don't have the equipment, you can have them do that at home. So what she should do is check her blood sugar and ketone. You can assess how well they're able to hold down fluid. So if she's able to hold down fluid, you can do a PO challenge in clinic. So when we checked her blood sugar was 100 and her ketones were moderate. And she drank 4 ounces easily in clinic. And her last insulin dose 3 hours ago was via an injection with no blog. So what are your aftercare instructions for this little girl? You have them follow diabetes sick day guidelines for moderate ketones, and have her drink sugary drinks so that she can take her correction for it as soon as possible. So since it's been 3 hours since her last injection, have her drink something. She may check her blood sugar 30 minutes later and correct for that. Okay, so a different case. This is a 13-year-old with known type 1, comes to the PCP with mild cold symptoms. She started to have abdominal pain in the morning, no vomiting. She has a history of poor control. She is on an insulin pump. She had blood sugars that were elevated overnight and was in the 400s this morning. So in the poorly controlled population, I think of them as always being ketotic. They always have some level of ketones in their urine, and it really doesn't take much to take them over the edge to moderate to large ketones. So, you know, when we hear stories like she gets a cold and she goes into DKA, she's just really brittle and vulnerable, I don't really like to perpetuate that thought because they feel like it is out of their control. What we really want to do is empower them and say, you know what, if we can get her A1C down from 12.5 to 7.5, she walks on solid ground. A cold is not going to throw her into DKA, it's going to be the flu or the stomach flu. And so, you know, this is the point in time where I think pediatricians can also help us out in saying, hey, let's follow sick day, let's get your numbers better. Okay, so, you know, given that she's had high blood sugars overnight, and she's given insulin through her pump and her blood sugars are still elevated, she most likely has a pump site malfunction. If you're able to give her a sub-Q injection for her high blood sugar in the office, that would be great. If not, then have her do that as soon as possible. Most patients are taught, even on pumps, that they should carry a fast-acting insulin pen on them. So if she's following kind of the instructions, she should have that on hand so that she can do a correction there. And you add 4 extra units for her large ketones. Have her start drinking 13 ounces of water. Have her change her site as soon as she gets home and increase her basal rate to 120% and continue to check every 2 to 3 hours with ketones and sick day guidelines. And if she doesn't get better, go to the ED. So one of my mentors in fellowship would tell me, you know, sometimes all these kids need who have a lot of ketones and they can't flush it at home is just to go to the ER and get a bolus. And it is pretty amazing. So that, you know, that kid that tells you, hey, I've had ketones and I haven't been able to clear them, they do go in, they get a 20 per kilo bolus and things clear up pretty quickly. So I do have a pretty low threshold of doing that. So all patients at ACH have been educated and provided these diabetes sick day guidelines. It is Important to be aware that early intervention and compliance with liquid intake and insulin can prevent many cases of DKA. If a patient has persistent vomiting, hospital management of ketones is needed. If ketones do not clear, an ED visit can help. And PCPs can help us remind families that need to follow sick day, and hopefully we can prevent some unnecessary hospitalizations. And that's the end of my talk, and I think we have a 15-minute break.